Hey guys, sorry for the little delay. Just getting ready for going into a shift here. Let's see if I can share this with one of y'all here.
Morning, everyone.
Good morning.
Hi, good morning.
Thank you all for joining us.
Thank you for this opportunity.
Hello, good evening
Good
from
evening.
Indonesia here.
Very nice to meet you. Thank you for joining us.
Nice to meet you.
Hello, can you hear me?
Yes, we can hear you.
Uh, good morning. I think it's morning where you are. It's late evening in Uganda, where I'm joining in from. My name is Sarah Orinawe. I'm an emergency physician. I just graduated a year ago, and I'm glad to be here.
We're excited to have you here. And of course, if you want to share any perspectives during any of this conversation, please do as well. We're just waiting. We'll give people a few minutes to join, and then one of our panelists was logged on, but it seems like they logged off again. So let me email them just to confirm.
Okay, awesome. I guess we will get started because it is 9. Hopefully, I think one of our panelists will join um, as oh as time goes on. So good morning, good afternoon, and good evening to some of y'all. Hello, everybody. My name is Shreya, and we have Aislinn here as well. We're part of the resident leadership for the Longitudinal Global Health Curriculum for Emergency Medicine residents.
And we're honored to have panelists joining us from Indonesia, India, Turkey. Our goal during this conversation is really to explore how emergency medicine is practiced, taught, and evolving globally, and what this means for trainees interested in global emergency medicine and international partnerships. We're so excited to have you all here today and to be able to learn from you all and your experiences. And because we have people joining us from all over the globe in multiple time zones, we recognize that this session is very early or very late for some. It's 6 a.m. where I am in California. And so, while it might be difficult for residents in this curriculum to be joining live right now, we're really excited for the broader group to be able to learn from this conversation and the recorded session and learn from this experience. So, again, just thank you all so much for joining us during this time. And even though we're a small group right now, there will be people watching this and learning from it.
Awesome. So like Aislinn said, we have some awesome, amazing panelists from different countries. We're hoping to shed light on different perspectives on international emergency care. A few housekeeping rules. I guess we have one person here who's in our class, but out of just respect for panelists, we want to keep this under pretty much within an hour. So if there's any questions or anything, just kind of hold them toward the end and we'll try to get to them at the end of the panel. So with that being said, we'll start in transition to our first question. So could everybody just briefly introduce yourself, describe your training pathway into emergency medicine and how emergency medicine is pretty much structured where you practice today? We can start with Dr. Uger if you want to. Go ahead.
You mean me? I'm sorry, I didn't hear.
Yes.
Okay, I'm sorry. Hi everyone, and thanks for this opportunity again. I'm excited to meeting with you. So this is very important, I guess, for the global emergency medicine. I am Dr. Yasin. I'm working as an emergency physician in Turkey, in Elazığ, the city of name of this Turkey. And I'm been this professional for approximately 4 years. And after graduating from medical school, I worked as a general practitioner 2 years. And finally, I completed my residency and I'm working 4 years emergency physician in Turkey right now. And our hospital has 24 emergency physicians, 16 residents, and approximately 40 medical practitioners.
Awesome. Thank you. Does anyone else? Dr. Mehta?
Hello, can you hear me?
Hi, yes, we can hear you.
Yes, Dr. Sarah Owerinawe. I'm an emergency physician practicing in rural Uganda in West Nile. I graduated a year ago from residency, and we have only 2 institutions in the entire country, that is Uganda, that train emergency medicine specialty. I am the 5th cohort, and I am the 9th emergency physician in the country, female emergency physician. So I serve an area that covers 5 districts, and I am the only emergency physician in that area. In my hospital, I'm still the only emergency physician in the hospital. However, there are other specialties like the orthopedics, the surgeons, the gyne and OB and pediatricians, but I'm the only emergency medicine specialist in the region. I find it bit intriguing and interesting at the same time, serving such a rural community. We also serve uh, a large group of refugees fleeing war from Southern Sudan and Eastern DRC. So that is the space in which I operate. I don't know if I have left in anything else that I needed to talk about. Hello, could you hear
Awesome.
me?
Thank you. Yes, we can hear you. Thank you so much. Dr. Habib, you
Thank
want to?
you. Yes, thank you very much. Hi, my name is Habib from Indonesia, Jakarta. Actually, in Indonesia, we just started the emergency medicine specialist program. Formally started about 4 years ago, and then I'm working in the National Referral Hospital in Jakarta, Indonesia, and we are starting the emergency medicine specialist program here. Now we have already 2 years for the total 4 years. Now I'm the secretary of the study program. Because we are starting the emergency medicine specialist, so my background is internal medicine. When I was starting my specialty, there's no emergency medicine specialist or emergency medicine study program. So after I graduate the internal medicine specialist, the government proposed us to continue the fellowship of the emergency medicine to the nearest country of Indonesia, that is Malaysia. So we have additional training in emergency medicine, and then finish the training and started the study program and emergency medicine service. So it's still ongoing, and we hope will be more sustained and have a good example from other countries. Thank you, Shreya.
Dr. Mata, would you like to introduce yourself?
Sorry, I cannot hear the
Yeah,
Dr.
sorry, I
Mehta
don't
point.
think we're hearing you very well.
We're still unable to hear you. Well, we troubleshoot. We'll try to add Dr. Mehta back and see if we're able to figure out the technological issues there. But thank you all for sharing kind of your paths to where you are today. I find it very exciting with emergency medicine being such a new specialty and the different ways it's becoming established, or the different ways people get to where they are and to be practicing in this field. One thing that we're very interested in this panel is really understanding how emergency medicine is practiced in these different settings. So I'd love to hear from you all, or what are some of the key challenges and strengths of practicing emergency medicine in your health system?
So I guess it is feel free. So I will share my experience. So the emergency medicine in Indonesia is a new species So, um, as a new species, we still have a lot of things to do to make sure that this kind of species is important and valuable in the emergency service, because previously the emergency service is filled by the general practitioners, and then direct to the specialists, such like surgeon, pediatricians, that do not have a specific background in the emergency medicine. So yeah, a lot of um, dispute regarding to the treatment and the planning and the education to the patients. And when the specialist emergency come, uh, we should uh, perform so we can have a significant, statistically and clinically significant performance before the emergency medicine era compared to after the emergency medicine era. So it's a lot of work for us in Indonesia, of course. So actually, I need sharing from college in other countries who already started the emergency medicine specialists many years before us. Thank you.
Thank you for sharing. It's exciting to hear as you're in a place of being like one of those first emergency medicine doctors and such. So thank you for sharing your perspectives. Would someone else like to share their experience and what key challenges and strengths they see in their health system?
Hello?
Hi, we can hear
Hello.
you.
Oh, okay, yes. Well, just like the person who has spoken, emergency medicine in Uganda and Africa generally is still a relatively very new specialty. And in my setting, we are very few of us that are going through residency and getting to stay in the country and work. So majority of my classmates and colleagues would prefer to stay in the capital or in cities where they will have like multiple jobs, and very few or even none would be willing to work in a rural, remote setting like I am in. It's where I currently work is such a unique space in that it is not just geographically unique in a way, but also the services are so limited. You have so little to work with, and yet the patients that come in, just like any other ED, will not tell you what they will come with. So I work in a space where I don't have a defibrillator, I don't have an EKG, I can't do some of the of the tests here, or even when I do them, the turnaround time is so huge, more than 24 hours. It's just of recent where folks from George Washington University are doing a project with my facility that brought for us a point of care ultrasound in this month. Actually, they brought it to me in this month. That's now, and at least I'm able to do an EFAS, look at the heart and stuff like that. But it's kind of tough. However, the good thing is that I have friends that I can consult remotely, and I'm trying to see if I can attract people to come and like support me, maybe even if it's for 1 week or even if it's for 2 days, I would appreciate it. I have challenges of the staff. They are not oriented to act and work like how an emergency system should be run. And it becomes really very difficult. Sometimes the drugs are not there. Like if you're managing a septic patient, you don't have noradrenaline to press that patient. I mean, it is hard and very heartbreaking most of the time, and depressing when you see a patient going down, and yet you have all this knowledge of what you could have done. So at some point I question whether I really made the right decision to come in a rural space. And I can't say that I really have seen good things yet, but I'm working on systems, having to convince the administration to line with you, to prioritize certain things, certain equipment, training of staff. I don't know. I don't know, but yeah, it's quite a challenge for me, and I would really welcome ways on how to overcome such huge challenges in my space. Yeah, thank you, thank you. Maybe I can add on as the conversations get going.
Thank you for sharing that. And I can't imagine how difficult all those challenges are. And thank you for sharing all that you're doing as well to work to overcome them and change things in the system. Does anyone else want to share their experiences and their health system in terms of key challenges and strengths?
Well, okay, maybe I can tell you something about our emergency medicine system in Turkey. Actually, the emergency residency is not a new thing in our country. Since 1993, we are starting the emergency residency in our health system. But our health system is free actually for the patients. So that's good for patients, but hard for us because everything is free, everything is coming in the ED, and despite or real patients or not, but they are coming all the times. So we are trying to choose the real and needing to more critical diagnostic factors. So this is hard for us, but this is the health system is free because we can see the CT, MRI, blood results, or a lot of things can make quickly. So this is good for us. So we can choose the patients and the critical illness going to the ICU directly and or transfer the big hospital. That's good for us. After the what about to be an emergency physician in Turkey? After the graduate to medical school, you are going to the exam like USMLE, and you are getting a point, and you are choosing any program, and you don't need any interviews. You're going to the program and you can start the residency. And the residency is 4 years in our country. After the 4 years, you can be an emergency physician and you can directly to working in like an attending physician.
Awesome. Thank you. That was a great transition into our follow-up question, I guess. So how does one become an emergency medicine or emergency physician in your country? So Dr. Yasin, thank you for starting off that question. And then I guess a follow-up sort of thing. I know Dr. Sarah kind of spoke on it about limited resources, but what does a typical sort of emergency department shift kind of look like in your country? In terms of volume, acuity, common presentation, staffing. I know we kind of touched a little bit up on it, but if anyone wants to answer.
And Dr. Mehta, now that we have you back on, let's see if we can hear you this time.
Yeah, I think I am now audible.
Awesome. We can hear
Yeah,
you now. You
audible.
didn't miss much.
Awesome.
We were just having everyone introduce themselves, describe their training pathways to where we are, and talking about their key
Right.
challenges and strengths in their health system. But we'd love to hear from you.
Yeah. So basically, I'm from India, and it is one of the highest populated country. So emergency medicine is one of the key department that the society needs that. And since 2010, there is a structured curriculum in India, and before that, there was no structured curriculum regarding national society. So Medical Council of India, that is the National Society for the Medical Education, started in 2010. That is the postgraduate program in emergency medicine. And since then, it is going on very fine. And along with that, MD, DNB, that is the Doctorate of National Board, another kind of graduation societies has started in corporate hospitals. So private as well as government hospitals both are running residency program in emergency medicine in India. Along with that, there are a few institutes that trains students for Royal College of Emergency Medicine, that is MRCEM. So another bunch of students, those who want to go outside, like in the Middle East or United Kingdom or Ireland or Malaysia. For them, Royal College of Emergency Medicine has started taking exams in India. They have 3 steps. So all 3 steps can be given in India. So, as far as emergency medicine is concerned in India, we have, you can say, 3 degrees parallelly going on. One is two are government recognized, and third one is for the international society, that is Royal College of Emergency Medicine. So, since last 15 years, I can say that it is very well established, recognized, and more in tier 2, tier 3 cities, they are employing the emergency medicine. So, initially, there were some resistance regarding the employment because it is not just that you take degree, but you need employment as well. So, employment is also increased since a decade. So, the attraction for the emergency medicine residency program has increased, and nowadays a lot of seats are also there. So, it has gone exponentially high as far as the number of seats in residency program is concerned.
Awesome. Thank you. Does anyone else have anything else?
In Indonesia, we have the national insurance program, so that cover all the people. But we also have quite powerful primary care. So the primary care centers in our country also have the 24 hours urgent care. So the mostly we have less of green zone patients. We have less green zone patients, and because most of the green zone patients come to the urgent care or the primary care, and if the patient insists to attend to the ED and the doctor decide that this condition is not emergency, and then the patient should pay the service because the insurance will not cover, the national insurance will not cover. This help us reduce the risk of overcrowding. But in my center, the national referral hospital in Jakarta, overcrowding is a daily basis because and most of the case is the proportion of the red and yellow zone is a little bit high, and because of the referral hospital, we also have quite many multiple comorbidities of the patients and palliative and terminally ill patients that come to the ED with the acute condition. So now one of the most rapid developed is the palliative emergency in our center because of the kind of situation in our patients.
Thank you for sharing.
Regarding,
And
go
ahead.
may I add something? So regarding of the yes, emergency medicine study program that still have a very few in Indonesia. So our hospital now have uh, 6 emergency physicians. Me also now uh, working as emergency medicine specialist in my hospital. I'm not working in the ward or outpatient clinic anymore, just focus on the emergency department. And we have a medical officer. The background is a GP. And we have also residents from other specialty that stay in the ED. They have 24-hour shift also. The resident is from the internal medicine, pediatric, surgery, orthopedic, and OBGYN. So we have a close activity with them regarding the management of the emergency patient and all neurologists also. They have stayed in the ED 24-hour basis. Thank you.
Thank you. And now that we've talked about how one becomes an emergency physician in your practices, we'd love to hear what excites you most about the future of emergency medicine in your country or globally.
I think we should hear from you also, Aislinn.
Well, in the US for us, we have 4 years of undergraduate, and then after our 4 years of undergraduate, we have 4 years of medical school. And after that, that's when people go into their specialties. So for us, emergency medicine is an established specialty that is either a 3 or 4 year residency. And then after that, people can go on to be emergency medicine physicians and attendings, or they can subspecialize in their fellowship. And I find it interesting hearing you talk about the green zones too, as we definitely have very large issues with boarding in the US. And we do see a lot of the lower acuity in the US in our emergency rooms as either people aren't able to access their primary care, or there isn't availability of appointments, or just a very difficult to navigate healthcare system as well. So we're finding it very interesting getting to learn from you guys and the way you guys mitigate some of those issues and what you all see as ways. And what excites us most? Sure, I don't know if you have an answer to that too, but
Yeah,
we'll think
so
about that one.
in my country,
What about, sorry, about the subspecialty? How many kind of subspecialty in your country?
Let me check. I don't know the number off the top of my head, but there's like ultrasound, wilderness, critical care, global health is one,
In
which
terms of
is what I'm going to be
fellowship
doing.
or emergency medicine, yeah,
Is it,
there's quite
yeah,
a few. There's critical care and sorry?
is it fellowship or subspecialty? Is it a different program, fellowship and subspecialty?
Yes. So from emergency medicine, it would be a fellowship. Most fellowships are 2 years post emergency medicine residency.
But they're optional. You don't have to do it. Another topic that we were hoping to touch on in this panel, especially given our audience, is global partnerships. And so we're wondering if you guys have had experience working with international partners before, and if so, what made the collaboration successful and sustainable or unsuccessful?
Yeah, so we had
well,
experience with working with Royal College, as I discussed, that, I'm an examiner for Royal College of Emergency Medicine as well. So it works well. Previously, where I was working, we had George Washington University MEM program, GWU MEM, if you have heard of George Washington University. So many faculties were coming from GW to India, and they were teaching our students. When I was studying, doing my residency program, we had a student exchange program with USCLA, so University of Southern California, and from there also we had a couple of faculties between 2010 to 2013. So, in my opinion, where the emergency medicine is very well established, like US, where you are, having such kind of specialties in years, decades. So, the transmission of knowledge to the countries like us in India, where now it's almost a couple of decades, where the specialty is well recognized, and then we can transmit the knowledge and experience to the countries where it is still in the infant stage. So that is how the knowledge transmission should work. And once we have gathered here tonight from different parts of the world, we can plan such things so that the developing countries are having emergency care in such a way that you guys are providing to your patients.
Yeah, maybe to add on what he has said, also what happens in Uganda is that we have visiting faculty from University of Calgary, from Royal College of Emergency Medicine Physicians in the UK. They come in to support the local faculty because we are still thin on faculty because most of us that graduate from residency end up starting to become faculty even without having to undergo the proper medical education training. So there is still a lot of collaboration that is going on, especially in our setting where emergency care is still getting grounded. So what makes these collaborations work is when they come over, we are taken over there on an exchange program. I did my elective training, for example, with the University of Calgary in India. So we were rotating in the hospitals, Foothills, Peter Lougheed, and Rocky View, having that kind of experience, going to the SIM centers and knowledge exchange. So that is one way that we can explore even with this longitudinal curriculum to see that we can support each other even in my setting. Like I had said earlier, I feel like if you guys came over, even if it was like for 1 week, you would maybe tell a story that is different, or you would see things through a different lens than I see them. But also to add on what I had said earlier, the positive thing about where I work is that it's a regional referral facility and all the care is provided for. You don't have to part with any money to access care. However, the challenge that poses is that we have stockouts. We can't do most of the investigations in the emergency setting. We don't have a CT, we don't have an X-ray, we don't have an EKG, we don't have a defibrillator. I mean, it is so much that I have to deal with on a daily basis. Plus, my team is also not well trained, so I have to work as I train the people I work with. It's kind of a daunting kind of task for me, really. And then I have to coordinate referrals from the communities. It is so much. However, we are here to support each other and to see how we can have this emergency care grounded, especially in countries like mine, where we are having most of the things at its infancy. Because I'm part of currently I'm part of the few people that are developing the training material for the lay responders. I'm thinking that could be one of the steps to help us when it is implemented eventually, so that at least our patients that come in have some degree of stabilization prior to their being received at the center where I work. Yeah, that's what I wanted to add. Thank you.
Thank you.
And can I say something too? Sorry.
Go ahead.
Please do.
Yeah, I had a wonderful experience in the United States last summer. thanks to ASAP and MGLEX family, I made an observership in Chicago, the many hospitals. And of course, I see the differences about our health systems. First of all, we don't have any fellowships or specializations, but I saw in Chicago simulation laboratory fellowship program, and it was very kind of different for us. But it's very joyfully actually because the medical education is very important in the United States. I saw that. Yeah, of course we are focusing of them, but the United States is one of the upper step for like this because they are very caring about theoretically the to be very correct, but our health system is trying to solve the problems in the practically in the ED. So yeah, that was a great observership, and actually I presented a global village in Las Vegas ASAP 24 like this one, and I'm still in touch with them. These are great things. I hope it continues and we become the be even bigger and beautiful family like global emergency medicine.
That's beautifully said. Yeah, I think it's important that we acknowledge that knowledge exchange plays a powerful role in reducing disparities across countries because it levels access, accelerates progress, and respects context. So it's very nice that you say that. And hopefully, this is what we're hoping to achieve in the future. And that's something that I am excited about, Aislinn. So hopefully, we can continue to do that. So I guess we can move on to the next question. What sort of advice, if you guys were to give something to somebody who's a global emergency medicine trainee that's interested in international work, what would it be?
I think for me, I would say that anyone doing global emergency medicine and maybe coming to a country like Uganda, for example, they should be having an open mind and willingness to learn in the sense that we have learned how to improvise and to use our clinical skills to the advantage of patient care and management. So when I said that I would go for my elective in other countries, the difference is that you will have a CT scan, you will have an EKG, but here you will have a patient passing out, maybe T colored urine, and then you're thinking, well, if it is not severe malaria, then it's maybe a rhabdomyolysis or maybe, and then you will be guided by history and your clinical exam to kind of tell, is this an AKI? And probably there is a component of hyper K. Is this because of assaults? And then this patient is having myoglobinuria. I mean, you have to think outside the box. Like we do not have the machines that will give you the tests on a snap of a finger. So that person should be open to learning and to share knowledge because the space where we are in, for example, me where I am in, I have learned to work like that, but it's such a draining kind of environment. So mentally they have to prepare that they have to still deliver or save a life with so little. Yeah, that's it. Were you hearing me?
Yes, thank you. Anybody else have any other advice?
Actually, that's the hard for to tell us because we don't have any global emergency medicine fellowship or something. But I saw my experiences. More networks is the more stronger doctor to be because is the some problems can be solved in another country than the different pathways, and you can solve your problem in your own country with this sharing about your experiences. So this is very important for us. And in my observership, I saw the some screens in the ED time to doctors, the triage to see the doctors, and it says us to 6 hours or something approximately. But I shocked because if it could be in Turkey like that, it can be a simple findings or somethings in emergency department because our see the doctors in green area or 10 minutes or somethings, and the red area in only 2 minutes to door to doctors because all about the systems actually because United States have walk-up clinics or pre-clinics or family medicine is very strong, but our in our country we don't have a strong family medicine control systems. So everyone coming the ED, so we have to decide very quickly, and we have to solve all problems very quickly. So yeah, we are. For example, I'm very happy to hear about Indonesia to protect their green area zones or walk-up clinic or something. Yeah, that's a good solution for me. And this in these meetings, and I get this, and maybe we can solve our problems like this.
Dr. Yes, and I actually just have a follow-up question. Is there somebody who's triaging, or who decides like who goes into what sort of area, if you don't mind me asking?
Uh, for example, our nurses is waiting in the triage area, and they're controlling the vital signs and the head of complaints of the patients. And they're deciding to you are going to the red area or yellow area because we are together looking the red and yellow area is the same area, and or green area or the trauma area. First of all, is if the going to the green area, the wrong patient, for example, the chest pain, sometimes that could be musculoskeletal systems pain. But if it's not correct, the general practitioners are calling us to red area to emergency physician, and they're thinking yeah, that could be at critical and going to transfer to go to directly to red area. But we don't have any a lot of problems. But we are the differences is like this. I'm sorry, maybe I'm talking too much. I'm sorry, but the system is like this. We are solving problems to communicate each other quickly because calling each other and yeah, can you take this patient? Yeah, I am taking this patient, and we are solving the problems quickly. The differences is in the United States, and nurses are very strong in the system, health system. They are making a lot of things, but in our health system, we are the first person the patients see us, not nurses, directly to us.
I'm just amazed at your wait times. Like we have people like 12 hours waiting, things like that. So the 2 minutes, 10 minutes, that's incredible.
Yeah, yeah.
Does anyone else want to share if they could give one piece of advice to global emergency medicine trainees who are watching this recording, who are interested in international work? What would it be?
Yeah, so one
Yeah.
advice for them is that, the emergency medicine structure and the practice is different in different countries and different continents. So if they are afraid of, having trained in US and then they go to Turkey or India, then the structure is completely different. As our triage time is very less, and within 1 or 2 minutes, patient would see a doctor. So that is the main difference between the healthcare systems. So wherever they are getting trained, but if they are moving to some other countries, then they have to be ready for the adaptation of their own systems, because the systems are very different. And here also, I mean, doctors are easily available, unlike US, where doctors are not so easily available. And that's why we get many patients from US with different kinds of complications, because they are not getting time or appointment with these specialists. So that difference is there, but otherwise the core curriculum and the concepts are same everywhere. So if they are taking global emergency medicine, then it's good that they are not binding themselves to some one particular system, but they are open to go to any of the systems, and that is very well. Recently, I was going through WHO different courses as and learning about mass disaster system and managing the mass disaster. So I was amazed to learn a new concepts. So they are also should be ready to know to learn new concepts regarding the development. It's a warfare area, and recently we had a symposium on toxins, terror time toxins. So we don't know what kind of terror toxins can come across, and being emergency physician, we are challenged every time nowadays. So we have to be ready, and we have to accept new challenges every time whenever we go on duty. So that is one thing an emergency physician should be ready for that.
Yeah. For me, I think we can use the online forum to increase awareness about the global emergency medicine, such like this forum, and then facilitate some discussions and maybe case report or something to share with others, college in other country, because some cases in India may be different with cases in from Indonesia or from Turkey or from United States. I think it is quite cheaper and but effective. So the online forum should be enhanced, I think. Thank you.
Thank you. I think we have time for one more question. Um, for our last question, we'd love to know, what do you guys wish you had known early in your career, if anything?
Actually, I wish I had made my residency in United States after my observership, because your theoretical education was great. I loved the lessons, but I make my practice again in Turkey, because the practice in Turkey is very complicated and challenging things. And of course, this is by the time this is the chaos. You have to challenge same time in 10 patients or 15 patients at the same time. But I wish I can get to the residency in United States, and I can get to all of your fellowships, because this is great. And thanks for Dr. Habib. Maybe we have to share a lot of meetings or case reports or a lot of experiences each other, and to be more stronger doctors in the global emergency medicine. Thank you.
For me, what I wish I would have known was I would have maybe someone would have sat me down and told me it was going to be tough and you would need to prepare yourself mentally, physically, psychologically, because the challenge I encounter is that I have so little support. Sometimes I wish maybe I had worked with maybe a senior person to help me navigate administrative challenges, clinical challenges, because I have been here, for example, for 5 months now. I have put in my request for EKG, defibrillator, and they're not being prioritized. So you like I am practically frustrated. So yeah, sometimes I wish someone had told me, especially for us who are working in spaces or in places where emergency medicine is still at its infancy, that we will need to do a lot of heavy lifting to make sure that people understand exactly what are you doing and support you in a way that is making sense and causing the impact and the change that we desire, especially in our setting. Thank you.
Okay, awesome. Thank you, everybody. If that's, I guess, all, I just wanted to thank you all once again. This conversation obviously highlights the power of cross-border learning in emergency medicine. We're so happy to have all of you here with us for these wonderful discussions, and hopefully we can continue to have more of these going forward. Thank you all for your leadership, your insight, your generosity, and for taking the time once again from your busy day to be here with us. So thank you. We hope you all have a wonderful rest of your day or evening.
Thank you for this
Thank you.
opportunity again. Thank you very much.
Thank
Yep,
you
Nice
for
to meet you
hosting
all.
us and
Thank you
for
all so
enabling us
much.
to share. Thank you. Bye.
Thank you. Bye-bye.
Thank you so much. Take care.